So very good evening, everyone. And after that talk by Shashi, it's now time to move on to the next molecule. It's not a new molecule, I would say. We all have been using it for quite some time now, Ivabradine. But recently, there have been some new developments on the Ivabradine front as well. Instead of twice daily dose, now we have the option of using an extended release preparation that can be given once daily dose. So we all are very well aware that any medication which is given in once daily doses offers a better chances of compliance on the side of the patients compared to a molecule which has to be given in twice daily or more frequent dosing patterns. So we will just be having a brief overview of the molecule, the indications, as well as how it stands and where it stands in compared to the newer guidelines that are now available. So this is how we are going to proceed. A few words about elevated resting heart rate, about heart rate control, about limitations of calcium channel blockers and beta blockers, then talking about Ivabradine proper. Then we would also be having a look at the clinical trials, the indications, the contraindications, and adverse effects of the drug as well. So gone are the days when elevated heart rate would be ignored as such. Now we all know it's not a benign entity. Framingham study over 30 years of follow-up, which compared all-cause cardiovascular and coronary mortality rates, suggested that elevated resting heart rate accelerates production of atherosclerosis, as well as it is associated with coronary plaque rupture and overall a poor prognosis on part of the patients. So what does heart rate elevation does to your body? So there are many things which go on side by side. Someone who has an elevated heart rate, we know the oxygen demand of the heart is increased. Someone who is having a increased resting heart rate for a longer period of time has a higher chances of going even into tachycardiomyopathy, which is depressed LV function because of persistently elevated heart rate. Then because of that, ventricular efficiency also decreases, ventricular relaxation time decreases. Heart rate also has a bearing on the comorbidities, increasing the chances of microalbuminuria as well. It has an effect on remodeling part, increasing cardiac hypertrophy. And then because of increasing oxygen consumption and decreasing diastolic length, and thereby decreasing coronary perfusion, it has a tendency to precipitate ischemia. And that is the reason why beta blockers or any molecule which lowers the heart rate gives symptomatic benefits to the coronary artery disease patients. And besides everything, it increases oxidative stress, decreases plaque stability, and ultimately also increases arterial stiffness, thereby hastening the process of atherosclerosis. So in patients with stable coronary artery disease who have LV dysfunction, elevated heart rate is a predictor of worse cardiovascular outcomes. So if you look at the graph, patients with elevated heart rate more than 70 beats per minute when compared to their counterparts with a heart rate less than 70 beats per minute have a higher event rate with passage of time, and the graphs go on diverging. And this study was published in 2019 in the placebo arm of the beautiful study that was there. So let's also have a look at the rate of coronary artery disease mortality and sudden cardiac death adjusted for cardiovascular risk factors according to heart rate values in men without pre-existing coronary artery disease. So this is a very interesting slide. You compare heart rate of less than 60, between 60 and 70, 70 to 80, 80 to 90, and more than 90. And when everything else is matched, even then, with increasing heart rate, chances of CAD mortality and chances of sudden death goes on increasing as a factor of increasing heart rate. So what do we do to have a good heart rate control? We have certain molecules which have been available for a very long period of time: calcium channel blockers, diltiazem, verapamil, beta blockers, the funny channel blockers, Ivabradine, and there are other molecules also, lanoxane, amiodarone, which can be used for heart rate control. But when we talk about controlling heart rate, do the molecules offer only heart rate control or pure heart rate reduction? Unfortunately, it's not so. None of the traditional drugs actually reduce heart rate in isolation. If you look at calcium channel antagonists and beta blockers, they are non-specific heart rate lowering agents. Besides heart rate reduction, they have many other effects on the cardiovascular system, like blood pressure lowering, actions on the systolic or diastolic cardiac function, and other systems. These effects may be intolerable or are in fact intolerable to many patients, and that limit the uses of calcium channel blockers and beta blockers in many of our patients. While calcium channel antagonists exert a potentially beneficial negative chronotropic action, their main action is negative inotropy. So that is another limitation on their part. They can again lead to adverse cardiac, like worsening of heart failure or AV nodal delay, and non-cardiac effects also, like worsening of constipation and peripheral edema. Similarly, beta blockers have many limitations. They are known to cause depression, in fact, worsen depression also. Diabetes mellitus patients are a concern, but now with the availability of cardioselective beta blockers, those are not really a contraindication or any concern to the use of beta blockers. Dyslipidemia, yes, the non-selective beta blockers had a tendency to increase triglycerides. Erectile dysfunction is a concern whenever we are giving beta blockers in the young patient population. Hypotension chances are there, and that is why we limit the uses of beta blockers when systolic blood pressure is more than 100 millimeters mercury. Intermittent claudication in patients with peripheral vascular disease, negative inotropy, obstructive pulmonary disease, in particular bronchial asthma or reactive pulmonary arterial disease should be the better word, reduced libido, and worsening of heart failure or AV nodal delay. So there are a lot many instances where we have to be actually careful whenever we are going ahead with beta blockers or calcium channel blockers. Now, there is also growing clinical evidence that more than half of patients with CHF who are on beta blockers have inadequately controlled heart rate. So even patients who are receiving optimal doses as described in literature, many have their heart rates not under the target levels. A substantial proportion of patients do not tolerate the target dose. So there are many practical limitations in using beta blockers. Moreover, further up titration of beta blockers is not achievable because of many reasons. This is of concern since elevated heart rate is associated with an increased incidence, which we already have seen, and that there is therefore an unmet need. What to do when we cannot give beta blockers? What to do when, in spite of giving beta blockers, heart rate are not under control? So here we have the option now. Option of using Ivabradine. It is a pure resting heart rate lowering agent and does not affect myocardial contractility, blood pressure, intracardiac conduction in the usual doses that it is prescribed, or ventricular repolarization. So how do these the molecule acts? So hyperpolarization activated cyclic nucleotide gated channels. They play important role both in control of heart rate and neuronal excitability. It is a mixed sodium and potassium channel that carries the funny current. Funny current was first described almost 30 years ago in sinoatrial node myocytes. It is a mixed sodium potassium inward current, controls the heart rate. Ivabradine, what it does is selectively inhibit funny current in a concentration-dependent manner, thereby reducing heart rate with no effect on myocardial contractility. So that is the molecule, the beauty of this molecule. It is only affecting the funny currents, thereby causing only decrease in heart rate or decrease in impulse production from the sinoatrial node without having any deleterious effect anywhere else in the body. So this is how it is working. The normal action potential is shown on the left. Ivabradine mediated slowing of diastolic depolarization. This is the red line, the red curve that is actually happening with using Ivabradine, thus lowering the heart rate. So where do we use this molecule? What are the indications? It is indicated for the treatment of chronic stable angina pectoris in patients with normal sinus rhythm who have a contraindication or intolerance for beta blockers. Now, let me make it very clear. In stable angina pectoris, beta blockers are the drug of choice when we talk about lowering the heart rate. For some reason, if the drug is contraindicated or if the patient is intolerant, there is the place we can use Ivabradine. For symptomatic treatment of chronic stable angina pectoris in CAD patients with normal sinus rhythm, it is indicated in combination with beta blockers. So beta blockers, unless and until there is a contraindication, have to have in the prescription for chronic stable angina patients. Additional indication of treatment of chronic heart failure in chronic heart failure class 2 to 4 patients with systolic dysfunction in patients with sinus rhythm. So again, here is the place where in a patient of chronic heart failure class 2 to 4, we are using beta blockers. The heart rate is not controlled. It is remaining more than 75 beats per minute. It should be used rather in combination with beta blockers. Or if for some reason beta blocker is contraindicated or not tolerated, there again we have a choice of using Ivabradine in chronic heart failure patients as well. So this is something which we have discussed, pure resting heart rate lowering agent. There are something which it is not doing, and that is the beauty of this molecule. Now, it is more active as the heart rate increases. This is again something which is a desirable effect. So when the heart rate increases, the channels are more often opening up, and that is the time when Ivabradine is causing, as a result of slowing of depolarization, more resting heart rate lowering. When the heart rate is lowered, Ivabradine has minimal effects because it is not able to effectively penetrate the hyperpolarization activated cyclic nucleotide gated channel responsible for funny current. So safety part is also to a large extent preserved because of this action of Ivabradine. Now let's have a few words about Ivabradine use in heart failure. As we discussed, elevated resting heart rate is an independent predictor of cardiovascular mortality and morbidity in both the general population as well as in patients with heart failure, irrespective of underlying ejection fraction. And why this is happening is actually multifaceted, relating to a number of things that we have initially discussed in that slide regarding mismatch between myocardial oxygen demand and supply largely. And in addition, acceleration of atherogenesis and coronary plaque instability. Patients with heart failure, we know, are in particular prone to higher resting heart rates because of the compensatory neurohumoral mechanisms which get activated in heart failure patients. Now, this drives an increase in oxygen demand and reduces ventricular efficiency, which ultimately worsens the heart failure. So this process goes on. And beta blockers actually, by blocking the sympathetic nervous system pathway, helps in cutting down on worsening of heart failure, also helping in remodeling and thereby imparting a mortality benefit to these patients. Additionally, higher discharge heart rates in patients with heart failure are associated with increased mortality and hospital readmissions. So the SHIFT study, this was the study which demonstrated reduction in heart rate with Ivabradine and produced consistent reduction of cardiovascular outcomes in patients with congestive heart failure, chronic heart failure. So this was the study which established this molecule in patients with CHF as an add-on therapy to the conventional therapy that was in use, including beta blockers and ACE inhibitors. What do the American guidelines say about Ivabradine? The 2017 ACC/AHA guidelines for the management of heart failure, it says chronic heart failure patients with class 2 to 4 symptoms with systolic dysfunction. So in patients who are in sinus rhythm with heart rate more than or equal to 75 beats per minute, Ivabradine should be used in combination with standard therapy, including beta blockers, or it can be used as a choice when beta blocker therapy is contraindicated or not tolerated for any reason. The European guidelines almost holds the same thing. Ivabradine should be considered to reduce the risk of heart failure, hospitalization, or cardiovascular death. Again, when the heart rate remains high in spite of using evidence-based doses of beta blockers, or when we have a contraindication to use of beta blockers. Ivabradine should be considered as an anti-anginal drug in suitable HFrEF patients as per recommended HFrEF management. So the two guidelines almost hold the same view when using Ivabradine in clinical practice. Now, what about Ivabradine in angina? The pathogenesis of chronic stable angina we know is complex, but basically it is the play of imbalance between myocardial oxygen supply and demand. And one of the reasons why oxygen demand increases is the elevated resting heart rate. So accordingly, heart rate reduction is a well-known strategy for improving both symptoms as well as quality of life in these patients. The heart rate reducing agent ivabradine is a direct and selective. It's the repetition of the same thing that is highlighted again and again, just to emphasize on how this molecule acts and how this molecule stands against other molecules in the same class. Trials involving more than 45,000 patients receiving treatment with ivabradine have shown that this agent has anti-anginal and anti-ischemic effects regardless of age, sex, severity of angina, revascularization status, or comorbidities. The European guidelines in their 2019 edition for the diagnosis and management of chronic coronary syndrome have also talked about ivabradine, that it should be considered as a second-line treatment to reduce angina frequency and improve exercise tolerance in patients who cannot tolerate, have contraindications, or whose symptoms are not adequately controlled by the traditional molecules that we have been using, beta blockers, CCBs, and long-acting nitrates. And in selected patients, the combination of beta blockers or calcium channel blockers with ivabradine may be considered for first-line treatment according to the patient profile. So coming to now the pharmacokinetics of the molecule. The absolute oral bioavailability is close to 40%. Food delays absorption by approximately 1 hour, but it should be taken with food. That is what is recommended in the inserts that are available. 70% plasma protein bound. I won't be going into the metabolism and excretion part. So the usual doses that we have been using for our patients is the 5 milligram twice daily dose or 7.5 milligram twice daily dose. But in elderly patient population, it's always a good idea to start with a lower dose, 2.5 milligram twice daily, and then up titrate as per the patient's response. Now, what about the extended release variant that is now available? So it is now available as 10 milligram once daily dose. The starting dose is 10 milligram OD with food. We can assess the patient after 2 weeks and adjust dose to achieve a resting heart rate between 50 and 60. The maximum dose remains 15 milligram. So there are certain special populations which are always considered whenever we are talking about a new molecule. What about pregnancy? So unfortunately, we do not have evidence to say that it is actually very safe in pregnancy. So unless and until we have a strong reason to use it, it should ideally be avoided in pregnancy and lactation. This is how the molecule stands at this point of time. Safety and efficacy of ivabradine again has not been established in patients less than 6 months of age. So pediatric use also is not recommended. In elderly patients, yes, it may be used, but then always a good idea to start with a lower dose because many elderly patient population also have underlying sick sinus syndrome, where even small doses of ivabradine can cause to large reductions in heart rate. Hepatic impairment, there are no data available in patients with severe hepatic impairment or severe renal impairment for that matter. Now, there are some contraindications. Let me tell you, even these contraindications are now finding ways for using ivabradine. Like there are many studies now which are using ivabradine in acute decompensated heart failure also. So initially it was used only for chronic heart failure patients who are stabilized. Now it is finding a use in acute decompensated heart failure. Clinically, very significant hypotension. Ideally, you should be avoiding any rate lowering drugs because many times that is the only compensatory mechanism available with the heart to try to achieve a reasonable cardiac output. Sick sinus syndrome, sinoatrial block, third-degree AV block. These are all contraindications for using this molecule. Clinically significant bradycardia because of any reason, yes, this molecule should be avoided. Severe hepatic or renal impairment that we just discussed. Heart rate maintained exclusively by the pacemaker. Then you don't want it to suppress the natural heart, the pacemaker of the heart. And in combination with strong cytochrome 3A4 inhibitors, because then we really don't know how the molecule is going to behave because of the concentration changes that occurs. Now, certain adverse reactions which are not that uncommon. Atrial fibrillation. Now, because this molecule suppresses the sinoatrial node, the chances of ectopics arising from other parts of the atria and even chances of developing atrial fibrillation is high in these patients. Bradycardia, any molecule which has a natural tendency to suppress the endogenous pacemaker of the heart, has an obvious adverse reaction of leading to bradycardia and conduction disturbances. Now, phosphines are described in literature. Fortunately, they are not very common at the usual doses that we have been using. Hypertension, they again are there in the literature. I'm not sure about how this actually stands in clinical practice. And then there are certain post-marketing experience like chances of developing syncope, hypertension, torsades pointis, BF, VT, angioedema. But again, there are even studies which show that ivabradine increases the threshold for ventricular fibrillation also and ventricular tachycardia also. So these are certain regions which are not very clear at this point of time. Pruritus, urticaria, vertigo, and even diplopia can occur sometimes. So concomitant use of certain molecules are not recommended, like cardiovascular QT prolonging medicinal products, quinidine, disopyramide, sotalol, ibutylide, amiodarone. Non-cardiovascular QT prolonging medications like pymoside, certinodone, mefloquine, or halofantrine. Concomitant use of these medicinal products with ivabradine should be avoided since QT prolongation may be exacerbated by heart rate reduction. So that is the reason or the rationale for trying to avoid ivabradine in combination with these molecules. Another contraindication or the area of concern we just discussed with concomitant use of potent cytochrome 3A4 inhibitors like azole antifungals, macrolide antibiotics, HIV protease inhibitors, and nefazodone. It ideally should be avoided. Now, clinical trials, I won't be going into the details of these trials. These have actually been the basis for making the drug available or making the drug now stand in the all the major guidelines across the globe. So the SHIFT trial, which was a landmark trial in chronic heart failure patients, we know how this molecule helped in not only reducing hospitalization, risk of hospitalization, in fact, went down by 26% with an absolute risk reduction of 4.7% when ivabradine was used against a matching placebo. Cardiovascular mortality also went down, although the numbers, the p-value was not that significant. Death from heart failure, when you consider, yes, you had a meaningful, significant 26% reduction in death from heart failure. In SHIFT, ivabradine showed consistent reduction of cardiovascular outcomes in patients with congestive heart failure, and similar results were seen in subgroup of SHIFT patients who were having angina. So all the more reason for using this molecule when the patient is having angina. The beautiful trial, again, it addressed ivabradine use in patients with stable coronary artery disease and LV systolic dysfunction. Used or enrolled, in fact, more than 11,000 patients between 2005 and 2017. The primary composite endpoint was a composite of cardiovascular death and hospitalization for MI and congestive heart failure. So acute MI admissions, they gone down, in fact, by when you compared a resting heart rate, which was reduced with ivabradine compared to placebo. Proportions requiring PCI, in fact, they are also decreased because of the symptomatic benefit that it was giving to the patients, and also because of reducing heart rate, the chances of plaque rupture and increased atherogenicity was decreased. So there were certain conclusions from the beautiful trial. While there was no differences on total cardiovascular mortality, ivabradine use appears to be in benefit in reducing readmissions due to coronary artery disease when resting heart rate was more than 70 in terms of reducing acute MI and coronary revascularization. Now, this was a recent addition to the trial base of ivabradine, the Proficient trial. This was a randomized double-blind phase 3 non-inferiority study with assess the efficacy and safety of ivabradine prolonged release OD preparation versus the immediate release BID formulations that we have been using. And let me just jump to the result. The change from baseline to 3 months was comparable between the two treatment groups. in terms of 20, when we had compared it by 24-hour Holter ECG monitoring, mean heart rate when the patient was awake and mean heart rate when the patient was asleep. So this would give you the added confidence for using OD preparations as against the twice daily formulations that we have been using so far. Bradycardia events reported were comparable between two groups. I just wanted you to focus here. It was not that when you were using 10 milligram once daily formulation, chances of bradycardia was increasing. So Ivabradine prolonged release was found to be non-inferior compared to immediate release formulations in management of patients with stable CHF with a comparable safety profile. The patients stabilized on Ivabradine twice daily regimen of 5 milligram or 7.5 milligram can be shifted to an OD regimen to effectively maintain heart rate with potentially added convenience and treatment compliance. Thank you so much for the patient hearing.
Thank you so much, sir. There is one question in chat box, sir, again. Again from Dr. A.K. Das, sir. In COVID infection, we saw lots of patients with sinus tachycardia. So would you recommend using Ivabradine in this setting?
I'm very happy. In fact, A.K. Das sir has probably listened to both the talks today. Thank you, sir.
Yes.
In fact, we have been using Ivabradine. And he's very right in saying so, because conduction disturbances, particularly inappropriate sinus tachycardia or unexplained sinus tachycardia, has been a very common finding in post-COVID patients. And many times there are limitations for using beta blockers because pulmonary function-wise, there are many a times presence of bronchi or some sort of bronchospastic factors also being there. So Ivabradine has been a very good choice in these patient populations also. Personally speaking, I have been using it in many patients of mine, and when their only concern was an increased resting heart rate to the tune of 120, 130 beats per minute also many a times. So yes, it is a very good choice in post-COVID patients.
Sir, there is no any question. So can I ask one question, sir?
Yes, Mukesh.
Yeah, in this setting, since Ivabradine you have recommended, so is it okay to use OD dose, or you better prefer go for that 5 mg immediate release preparations? Which one you would prefer?
Mukesh, personally speaking, I have been using only BD formulations till now. But yes, compliance remains a very major issue, and patients are always keen on at least reducing the number of drugs that they are taking. So you talked about congestive heart failure, you talked about chronic stable angina. There are many medications which the patients are on at the same time: aspirin, another dual antiplatelet, statin, ACE inhibitors, MRAs, diuretics. So reducing it to once daily doses also means to the patient that the number of drugs are decreased. So that is one part which is again important when you consider it from the patient's perspective. And yes, we have data to suggest that whichever drugs are available in oral formulations, compliance has always been better compared to the drugs which have to be taken in twice daily or thrice daily doses.
Thank you so much, sir.